Hello everyone. Today we are going to talk about the Judkin's left catheter, which is one of the common catheter we use during the coronary interventions. So there are two catheters, that is Judkin's left and Judkin's R, and should know all about these catheters because these are frequently asked in your practical exams as well as for your clinical practice. Also, you should be aware of what are the limitations, advantages of each of them. So Judkin's left is the mainly one which is used to left coronary artery for left coronary artery engagement. We use that, and so you can see here this is the normal shape of the Judkin's left. So there are two curves in it. You can see as we can see here. So this is the primary curve which you can see here. So this is the curve. So this is the primary curve, and this is the secondary curve. So the secondary curve and the primary curve. So based on this curve, why this curve is important? Because based on that, we decide the size of the catheter. Usually the distance between the secondary curve and the primary curve, that decides basically the size of that. Usually we can say that sometimes we use JL 3.5, 4.0, 3.0. See, this is all decided based on the distance between the primary and secondary curve. So how can we pre-operatively or pre-procedure can calculate that is, you can do is one thing importantly, you can calculate the aortic root dimension. You can measure this dimension from here to here. So once you measure this dimension, so this will roughly give you the idea of how much size you should select. Suppose this aortic root is that is 3 centimeters, the size is there, then you can actually select based on that. So also important thing is that whenever you put a catheter, it has to be coaxial. Coaxial means the direction of the injection when you inject should align with that of this is left coronary artery, should align with that. So this is the coaxial one, this is the non-coaxial. What are the other key features of JL guide is this has primary curve. As you can see, this is the primary curve. Usually this is 90 degree. So this angle here is 90 degree, and the secondary curve is here. So which is usually 180 degree. If you take the normal catheter, which will be shown. So see that the normal shape of the catheter is like this. This is the primary curve. You can see here, this is 90 degree. And the secondary curve is between this and this, and is actually, you can see it is 180 degree, somewhere around that. So based on the size, which I said that, so suppose this is narrow aorta or small patients, based on the height, if it's a small, you can select JL 3.5. If a standard patient, usually the JL is 4.0. And for wider aortic roots, you can use 4.5 to 6. So narrow aorta 3.5, for all other normal patients is JL 4.0. So normally the design of the JL is in such a way that you can see this align in such a way that it goes and sit into the aorta automatically. So suppose you are passing a JL guide through a femoral artery, you do not do much manipulation if unless and until your operator do some problem. Usually if it's sent properly in this direction, it automatically goes and sit into the left ostium. So it is designed in such a way that it automatically go and sit there. So that is its natural nature. But only important thing is that only a small part of the catheter, you can see only the small part of the catheter only hooks into the left main here, because this is the curve which is there. So the whole of the catheter does not go inside. Only a part will be there. That is a small part will be there. And thus, it is a very important catheter when you want to intervene the left main disease. Why? Because this does not go very much deep and cannot disturb the plaque also. So it just sit in the ostium, small part of that, and it is very safe for the ostial disease or left main diseases as well. But limitations because of this small thing is that whenever you pass a catheter here, because of this 90 degree acute 90 degree angle, what happens is passing of the balloons or a bigger balloon or bigger stent, some difficulty can always be faced. So advantages is that it minimizes trauma because it only incorporates a small segment of the ostium. Thus, risk of injury to the vessel is less. Predictable navigation, as I said already, that the shape itself is designed in such a way that it directly goes and sits into the coronary ostium. And for the support, so important thing is also here to be noticed that the support of the catheter. Usually the guide, this JL guide usually takes support of the opposite aortic wall. That means that guide sits here in this wall. So it takes the support of the wall and sits here. So this is the support here. So basically if this sits particularly here, that's why we are measuring the distance here. So only if it is there, then only support will be there. Otherwise, this coronary catheter, this starting point will have very less support and can get dislodged very easily. So coming to the limitations, it has a fixed primary curve, so it may not always be coaxial. Suppose if you have anomalous coronary artery, it may not sit very properly in that, and limited backup support. It is takes the support of the opposite wall. It does not have a whole support as such, because when you take EBU take the support of the whole aortic annulus. That means EBU comes in this direction like this and goes and sits into this. So it takes the support of the entire aortic annulus supports is taken. So extra backup EBU catheter, that is extra backup catheter, has a more support when compared to the JL catheter. And also because of the 90-degree angle, as you have said, that there will be difficulty in passing the balloons and catheters in the jail. Thank you.